Welcome to UMedics, a health learning platform. Chest X-ray. It is a common diagnostic tool that is used to visualize the airways, the lungs, the heart, the vessels, and the bones of the thorax. The organs in the thorax as presented on chest X-ray. We have the trachea, the clavicles, the carina, the posterior and anterior ribs, the spinous process, the right and left hemidiaphragm, the scapula, and the mediastinum with the left ventricle and right atrium. The more X-ray beam passes through structures and hit the X-ray plate, the darker the appearance, and the less X-ray beam passes through structures and hit the X-ray plate, the whiter the appearance. The structures that are more dense or with high density absorb more X-rays and appear lighter on the image, while less dense structures allow more X-rays to pass through and appear darker on the X-ray plate. So the darker X-rays areas on X-rays indicate that more X-rays have passed through those structures and hit the plate, while the lighter areas indicate that fewer X-rays reach the X-ray plate due to absorption by the denser tissues. The air in the lung parenchyma appears black. This is due to its low density. There is minimal absorption or scattering of the X-rays and a high transmission of the X-rays through the air onto the X-ray plate, and so air appears black on the plate. Water or tissue appears gray. Fat appears dark gray, and soft tissue such as the heart and the muscle appears light gray. But the bones such as the ribs and the spine appears off-white, and any metal in the chest appears bright white on the chest X-ray. The structured approach to X-ray interpretation. A. Confirm patient details to be sure you are dealing with the right patient. Assess the quality of film. Then ABCDEF approach used in interpreting the chest X-ray. In confirming the patient details, you begin chest X-ray interpretation by checking the following details on the chest X-ray: the patient details, the name of the patient, the date of birth or age of the patient, and any unique identification number, the date and time the film was taken, the facility the film was taken, and also any previous X-ray available for comparison. You then assess the quality of the film. That's how well the X-ray captures the structures of the heart. And in doing so, the mnemonic RIPE is used: R rotation, I inspiration, P projection, E exposure. For rotation in an X-ray procedure refers to the proper alignment of the patient's body. The patient should be positioned so that the mid-surgical plane of the patient is perpendicular to the X-ray beam, allowing for an equal view of the structures in the thorax. Also, the spinous processes should be vertically aligned. How to assess rotation on chest X-ray? You measure the distance between the medial edges of the clavicles and the vertebral spinous processes. The distance should be approximately equal on both sides. This shows there is good rotation. You note that if the patient does rotate, the side they rotate or turn towards will have a greater distance as compared to the other side. I inspiration, and that's the depth of breath taken by the patient during the X-ray. A good quality chest X-ray is taken at full inspiration, where the patient takes a deep breath and holds it. This expands the lungs fully, allowing for better view of the lung fields and structures. If there is adequate inspiration, the diaphragm should be at the level of the posterior 10th rib. You know that if the X-ray is taken during expiration, that's when the patient exhales. The lungs may appear smaller and the structures may not be seen, leading to misinterpretation. And also, an expiratory film may resemble pneumothorax due to reduced lung volume during expiration. How to assess inspiration on chest X-rays? You check the apex, the bottom, and the lateral aspect of the lungs. The lung apices should be visible. 5 to 6 anterior ribs should be visible, Both costophrenic angles should be visible, and the lateral rib edges should also be visible. This shows there is adequate inspiration. For projection, this refers to the angle and direction from which the X-ray beam is directed at the patient. The most common projections for chest X-rays are the posterior anterior view. The posterior anterior view is taken with the patient facing the X-ray plate and a beam traveling from posterior, that's the back of the patient, to anterior. Note that the PA film is the most common film and is usually only taken in X-ray department. And the AP film is usually taken in acute or critical care settings where the patient is sitting up in bed and the plate placed behind. How to assess projection on chest X-rays? In a PA film, the scapula are positioned more lateral and the clavicles appear lower, more curved and further apart. And in AP film, the scapula overlap in the lung folds, so appear more medial. The clavicles appear higher, straighter and closer together. For exposure, this is the amount of radiation used to create the X-ray image. The ideal X-ray allows the right amount of penetration through the chest so that the X-ray would be properly interpreted. Under-penetration occurs when not enough X-rays pass through the body. This results in no structures being visible behind the cardiac outlines. And over-penetration, more X-rays are being passed through the structures onto the X-ray plate. This results in an X-ray that is too dark, where the fine details are unable to be properly viewed. How to assess exposure on chest X-rays? The vertebrae should be visible behind the heart, and also the left hemidiaphragm should be visible to the spine. This shows there is good exposure. ABCDEF approach that is used in checking for any abnormality of the chest. A. Airway. So check the trachea. Inspect the trachea for evidence of deviation, whether there is deviation toward or away from the affected site. The trachea is normally located centrally or deviated very slightly to the right. If the trachea appears significantly deviated, inspect for anything that could be pushing or pulling the trachea. And also make sure to inspect and or palpate for any paratracheal masses or lymphadenopathies that could be causing the deviation. The causes of tracheal deviation toward the affected site or pulling of the trachea. This occurs due to volume loss. In significant atelectasis, lung collapses where the air sacs becomes deflated. There is decreased pressure and pulling of the trachea. And also in consolidation with associated lobar collapse, there is volume loss, and so there is pulling of the trachea. Also, causes of tracheal deviation away from the affected site when there is pushing of the trachea away from the affected site. This occurs due to volume expansion. In large pleural effusion, fluid in the pleural space pushes the trachea, and also in tension pneumothorax, air in the pleural space and cannot escape, leading to increased pressure in that space that pushes the trachea. Also inspect the carina. On an appropriately exposed chest X-rays, the carina is visible and located in the midline. The carina is a cartilage situated at the point at which the trachea bifurcates into the left and the right main bronchus. And causes of the carina being obscured: poor quality film, pathological conditions such as the large pleural effusion, overlapping structures when the heart or large blood vessels obscure the carina. Also inspect the bronchi. The right main bronchus is generally wider, shorter and more vertical than the left main bronchus, and it is more common for inhaled foreign objects to become lodged in the right main bronchus. The bronchi are directly not visible on chest X-rays, but they can be seen based on the pattern of air and fluid in the lungs in the case of pneumonia, as well as any abnormalities of the bronchi. B. Bows. Check both clavicles and the pair of ribs one at a time for any fracture, deformities, and or any missing bone. Also check the spine for any deformities. The spine should be vertically aligned, and look for any curvature of the spine. When there is lateral curvature of the spine, that's in scoliosis. Clean chest X-rays can be used to confirm the clinical diagnosis of scoliosis, to identify a cause, and to grade the severity of the scoliosis. C. Cardiac shadow. You check the site, at the mediastinal shift, and also the direction of the apex, whether it's left or right side. With the mediastinal shift, look for deviation of the mediastinum toward one side of the chest. Causes of mediastinal shift as mediastinal mass, any lung volume loss, that's insignificant atelectasis causing pulling of the mediastinum, lung volume expansion in large pleural effusion causing pushing of the mediastinum. Also note that threatened deviation is a sign of upper mediastinal shift, but not always. And also deviation of the cardiac shadow is a sign of lower mediastinal shift. Also look for any dystrocardia where there is inversion of the cardiac shadow with the apex pointing the right side. You inspect the size for any cardiomegaly. In a healthy individual, the heart should occupy no more than 50% of the thoracic width. In cardiomegaly, if the heart occupies more than 50% of the thoracic width on a PHS X-ray, that's when the cardiothoracic ratio is more than 0.5. Assessment of the heart size. Use the cardiothoracic ratio, where you take the cardiac width divided by the thoracic width. The cardiac width is measured from the right edge of the right atrium to the left edge of the right ventricle. You also note that the cardiac shadow will be artificially widened on an AP film, and conclusions should not be drawn. Causes of cardiomegaly: valvular heart disease, cardiomyopathy, pulmonary hypertension, and pericardial effusion. You check the shape of the cardiac shadow. The cardiac outlines is normally ovate in appearance, with the apex pointing toward the left. Some abnormal shape of the heart, as a boot-shaped heart, you look for an upturned apex with a concave appearance of the main artery, which is a sign of tetralogy of Fallot. And a water bottle-shaped heart, look for diffuse enlargement of the cardiac shadow with a globular appearance. This is classically a sign of large pericardial effusion. Also inspect the borders, the ciliate sign. Look for any obliteration of the normally clear cardiac outlines between the lung fields and the adjacent structures, that's the heart and the aorta. Any loss of normal borders appear when the adjacent area of the lung is consolidated, where there is fluid, pus, blood, or other substance filling the airspace, or when the lung is collapsed. D. Diaphragm. The right hemidiaphragm is usually 1 cm higher than the left due to the presence of the liver, and the stomach is below the left hemidiaphragm and is best identified by the gastric bubble located within it. The diaphragm, check the diaphragmatic position. The posterior ribs of 8 to 10 and 5 to 6 anterior ribs visible in a normal chest X-ray. So diaphragmatic elevation, that the number of visible posterior ribs decreases due to elevation of the diaphragm, and this is caused by intra-abdominal pathology such as ascites and tumor. And with diaphragmatic flattening, the number of visible posterior ribs increases, which is caused by hyperinflation in emphysema and large pneumothorax. The costophrenic angles. Check for any costophrenic blunting. Look for the loss of the normally sharp angle between the diaphragm and the chest wall laterally, and this is a sign of pleural effusion. Also look for any deep sulcus sign, which appears as deep, lucent, and a sharp black airline in the cosophrenic angle that extends towards the abdomen. The deep circle sign is caused by air collecting in the pleural space, which deepens the lateral cosophrenic angle, and this is a sign of pneumothorax. Also check for any diaphragmatic hernia. Look for the appearance of bowel within the mediastinum with air or fluid levels present. In causes of diaphragmatic hernia, we have hiatus hernia and congenital diaphragmatic hernia. E. Extrathoracic tissues, you check for any breast shadows or air trapping. F. Fills and the fissure. We inspect for any inflation, any consolidation, any loss of lung markings. For inflation, normally 6 anterior lobes and 9 posterior lobes should be seen above the diaphragm. And in hyperinflation, look for diaphragmatic flattening, where there is 10 or more posterior lobes visible above the diaphragm. And hyperinflation is a sign of emphysema, though it can rarely occur with other obstructive diseases such as asthma and bronchiectasis. And in underinflation, less than 8 posterior lobes visible above the diaphragm, and it is caused by poor inspiratory effort or atelectasis. Consolidation, it indicates filling of the air sacs in the lungs with pus, fluid, blood or cells. You note that consolidation is not equal to opacification. Consolidation occurs when air-filled alveoli are replaced with fluid, pus, blood or cells. They typically cause opacification. Opacification, on the other hand, is just the loss of normal lung transparency, appearing as whiteness on radiographs. So for consolidation, look for opacification, that's whiteness in the lung field. The sinus sign, the obliteration of the normally clear outlines between the lung fields and adjacent structures. And any loss of the normal borders appears when the adjacent area of the lung is consolidated or collapsed. Also check any air bronchograms. Air-filled bronchi visible within the opaque area, which is caused by pneumonia, pulmonary edema, atelectasis, acute respiratory distress syndrome. For instance, in the case of pneumonia, the bronchi stand out more clearly on imaging because they are filled with air, whereas the surrounding tissue appears denser due to the presence of fluid caused by inflation. And also check for any there is no loss of lung volume. For consolidation in pulmonary edema, there will be a bat wing appearance. The hilar region is where the bronchi, arteries, veins and nerves enter and exit the lungs, and perimeter is around. So you look for a central bilateral perihilar distributors of consolidation on chest X-ray, and the bat wing appearance is classically a sign of pulmonary edema. Also note that pleural effusion itself does not cause consolidation because the fluid is in the pleural space and not in the air sacs as in consolidation. It can only occur alongside with other lung conditions that cause consolidation. For example, a large pleural effusion can compress the lung and lead to atelectasis, which may contribute to the appearance of consolidation on imaging. Also check any loss of lung markings. Those are the small blood vessels that appear on the chest X-ray. Causes of reduced lung markings, pneumothorax and emphysema. So these are the things to look out for during its interpretation of chest X-ray. In summary, you confirm the patient details by checking the name of the patient, the date of birth or age, and any unique identification number, the date and time the film was taken, the facility the film was taken, and any previous X-rays available for comparison. You then assess the quality of the film by using the mnemonic RIPE: rotation, inspiration, projection, and exposure. You then use the ABCDEF approach in interpreting the X-ray. Airway, check the trachea position, the carina, the bronchi. For bone, check the clavicles, the risk for any fracture, deformities, and or missing bone, and the spine for any deformities. C. Cardiac shadow. Check for the site, the size, the shape, and the borders. D. Diaphragm. Check for the diaphragm position, whether there is any diaphragmatic elevation or diaphragmatic flattening. Also check the cosophrenic angles for any cosophrenic blunting or deep sulcal sign. And also check for any diaphragmatic hernia. E. Extrathoracic tissue. That's if there is any breath shadows or air trapping. And F is the fill, the lung fill. You check for any inflation, consolidation, or loss of lung markings. In presenting findings of a normal chest X-ray, this is an X-ray. This is a chest X-ray of Mr. Johnson Akinyemi, a 57-year-old man. The X-ray was taken on October 28, 2023 at XY Hospital. There are no previous X-rays available for comparison. The X-ray is of good rotation, with the medial clavicles equidistant from the vertebral spinous process. There is adequate inspiration evidenced by 6 anterior ribs and visible cosophrenic angles on both sides. This is a posterior anterior X-ray. The exposure is also good, with the vertebra clearly visible behind the heart. The trachea is centrally placed, with the carina visible and located in the midline. There is no evidence of rib fracture or deformities, and the spine is vertically aligned. The heart size is normal, evidenced by a cardiothoracic ratio of 0.49, and the cardiac outlines has well-defined outlines. It's well-defined. The cosophrenic angles are normally sharp, and the lung fills are clear. This is how to present your findings of a normal chest X-ray. I hope this was fun and educative. Kindly like, subscribe, and share. Also put us on post notification.